Hi, thank you for joining us today. My name is Hiral Shah. I'm one of the therapeutic endoscopists and the director of research here at Lehigh Valley Health Network and part of Eastern Pennsylvania Gastroenterology and Liver Specialists.
And I'm Shashin Shah, the Director of Endoscopy at Lehigh Valley Health Network and also a partner and therapeutic gastroenterologist with EPGI.
And we appreciate you joining us today. We're here to share with you some of the findings and results and information we've been able to gain from our study, which is publishing in Gastrointestinal Endoscopy in a couple of weeks. Our study is titled A Prospective Head-to-Head Comparison of 2 EUS-guided liver biopsy needles in vivo.
Dr. Shah, why did you feel the need to do this study?
So that's an important question. Thanks. Our study is really gaining knowledge and more information about endoscopic ultrasound-guided liver sampling and biopsy results. Traditionally, endoscopic ultrasound guided approach was not being done until the last 10 years or so, where it's gained more acceptance. And again, traditionally it was done percutaneously. However, with the advent of endoscopic ultrasound and the ability to provide this resource for patients, we're able to not only do an endoscopy and evaluate for liver diseases such as common findings of varices, portal hypertensive gastropathy, and such, but we're also able to access the needle biopsy of the liver directly to gain information and knowledge of underlying liver diseases. And so these two things hand in hand, we felt was important for not only patient care, but also for the diagnostic yield. Up until this point, we have not really had a standardized approach, and nor do we know if there is a high yield of liver histology in this approach and different techniques that could provide better yields and such.
Yeah, exactly. I mean, for 30, 40 years, the percutaneous approach was the way to go, and there's a lot of doubt as to whether we could obtain similar specimens doing it through EUS guidance. So being able to show the GI community, hepatologists, and pathologists that we can give as good a specimen with less risk, less morbidity, and potentially diagnose other conditions at the same time while the patient's asleep was what we needed to do for the field.
Excellent. And so Dr. Shah, what does your study add to the existing body of knowledge that is out there?
So endoscopic ultrasound, again, has been used for many years now, but endoscopic ultrasound-guided liver biopsy still needs more data and knowledge as far as standardization and techniques for sampling. Certainly, we do feel that this approach can be helpful for the patients for looking for underlying liver disease, ruling out underlying biliary diseases that may be present, and if not, perhaps they do have true underlying liver disease, but also aiding to the ability to provide a approach that can be safer for a patient.
Great. And Dr. Shah, can you go into the design of the study, and in particular the needles used to obtain liver specimens?
Sure. And this is some of the wonderful parts of the study. We used 2 competing needles, one made by Covidien called the Shark Core FNB, a fine needle biopsy system. It was a 19-gauge needle with a 4th tip that allows a direct cutting edge to go into the liver to obtain an intact core, while the second needle was a 19-gauge Acquire needle made by Boston Scientific that's the traditional Francine needle that has been used for 30 to 40 years or longer in the percutaneous liver biopsy approach. So those are the 2 needles we used.
In addition to the design of the needles for our study, we did 1 pass with 3 actuations with each needle, and we're able to develop a comparison in our study design to see the histology differences in pathology yields.
And where I think this actually benefited us was using a wet suction heparin prime technique. So actually using heparin through the needle and having it drip out the end so that we prime the needle itself, and then using wet suction to provide better negative pressure for the needle when we enter into the liver parenchyma. Then once we get the tissue specimen and we plate it on a plate, we're then able to use heparin to wash away the blood clots, if there are any, so that we can see and visually diagnose the intact cord.
That's wonderful. And Dr. Shah, can you go over the overall results of the study and what we found?
Absolutely. I think the kind of the crux of the study is to see if we're providing information that we need. We need good liver histology, and the purpose of this study is to see if there's a difference in the design of the needles and to help provide more future standardization in this technique. And certainly, again, as Shashin, you alluded to with our study design with the needle fork tips, we were comparing the fork tip to the Francine design of the two needles. And we were studying it from a statistical perspective, the adequacy, the diagnostic yield of the liver sampling, as well as the intact core, which is very pertinent to the pathology diagnosis in these samples. In particular, we looked at the fork tip design to the Francine with regards to diagnosis and did find a significant difference of an approximate 80% with the fork tip design to a 97% diagnostic yield with the Francine design needle. And that also resulted in a portal triad difference of the fork tip showing an approximate portal triad of 7 to a portal triad of almost 10 with the Francine design.
Exactly. And that's what I think we need to convince our hepatologists with. Can we get a diagnosis? Can we do it safely? What are the number of portal triads? And this is what they want to know, and this is the information we're providing to them.
So again, I hope this video provides you with some information as far as what we're doing at our center, and it helps everyone at your center. I think it's crucial that your team, like we did, have conversations with all the folks involved, including radiology, pathology, your interventional endoscopists, and really create a team approach in deciding what's best for your patients, your patient care, your center, and providing the best results.
Yeah, and we've been able to take that back to hepatologists and develop a whole protocol for patients who have either abnormalities or those who may be included in studies. So that's something that you may be able to do at your center as well, to see if you can develop a liver biopsy program in conjunction with your pathologists and hepatologists.
I'd like to thank you, and certainly reach out to us if there's any questions. We'd be happy to collaborate in any way we can. Thank you.